Hi, my name is Frank Caputo. Welcome to Drugs Are Us. This program is dedicated to explaining drug abuse, drug addiction to the families of those who may have someone that has a problem or potentially has a problem. My guests tonight are Diane, who is an RN who works on the inpatient mental health unit at Bristol Hospital. It's a combined unit, which means that we do detoxes there as well as other mental health issues. I also have Gwen Crowley, who is a crisis counselor, and she works out of the emergency room in a separate area all by herself, and is the first person to see when you get there. I'd like to begin with Gwen, because the sequence will go, person has to come to the hospital because of a crisis situation that's related to drugs or alcohol, and somebody will contact Gwen, right?
Right.
How does that usually happen?
Well, after the initial arrival at the ED, the doctor, they do a medical evaluation of the person. They have to determine if there's any medical complications, if there's illnesses, anything that needs to be addressed or stabilized. Once the person is stabilized, then I'm called to come over and consult and find out exactly what the patient wants. If they want detox, find out what it is that they exactly want. Detox, many times they don't know what the medical procedure is. Maybe they just want to stop using whatever substance they're using. So I begin by giving them a little bit of information, education. Then we gather information from them. And it's very important to collect data in terms of quantities of drugs, length of time used, how they use the drug, if they've ever had treatment before, aspects of the treatment that they felt beneficial. Collecting all of this information, it helps sort of frame a picture of how successful they might be in the treatment they're going to receive on the inpatient unit. And also it helps doctors, sometimes the information I collect hasn't been explained to the doctor simply because it wasn't asked. So we get a very extensive background history, family history of usage or treatment or any other kinds of scenarios. Finding out if they have support systems is very important, also because follow-up treatment on the mental health floor and then afterwards, it's very important to have a support system. So knowing if they have one when they're coming in, it's good to know that they'll have one on the way out as well. So that's basically in terms of my interaction with the patient. And then consulting with any medical staff if they need anything, if they're feeling jittery, if they're going through any kind of withdrawal symptoms, I can request some medical assistance, usually just some medication or something as simple as a nicotine patch. And sometimes people just need a sandwich. So that can be very, very supporting, right, just initially. Then after that portion, I then consult with not just the doctor and the nurse and the ED, but also with our on-call psychiatrist, who ultimately will make a decision as to whether the patient really is in a condition where he or she needs to be in the hospital for the treatment, or if they can receive this treatment on an outpatient type basis, or on a sort of another stage in the treatment would be not a hospital, not outpatient, but a residential facility where a little bit of medication is given to keep the person comfortable. They're also given some education around the substance use, and then discharge planning is done with them there. So there's a lot of varieties of treatment available, and although they come to the hospital, I let them know what is available and where they might be directed. So
when they come to see you, when they go to the emergency room, or if they call, do they just call and say, I've been on heroin for 3 years and I need a detox, you got a bed? You know, I mean, that's not that simple.
Well, that is one of the types of conversations. Many people, anything. Some people are really looking for the nuts and bolts. They want to know, am I going to be uncomfortable? Am I going to be in pain? They want to know everything so they're sure. Some people just say, I really need help. And it can be, the motivation can be lots of different reasons. On the phone, I personally don't try to get into that because I'm not trying to talk anyone out of anything, or I would encourage them to come in, of course, always, at least for the initial medical evaluation. But on the phone, we'll give them information as to whether we have a bed, how the admission decision is made, not by us, by the doctor. Also adding in the piece about insurance coverage. And people with all sorts of backgrounds come in terms of insurance, anywhere from private insurance to state insurance, out-of-state insurance, or no insurance. And there are facilities to accommodate everyone. And it's a matter of finding a bed if the facility will accept them. And so there's a lot of after work after I speak with the patient, a lot of after work that has to get done. And then I do try to let the patient know exactly what stage I'm at, because it's terrible just to sit in the room and not know what's what. Right. And so we go.
So there's a variety of things.
A variety.
When a person comes into the emergency room and wants to see the crisis counselor, that doesn't necessarily mean that they're going to be admitted to the inpatient unit. That doesn't necessarily mean they're going to be refused admission because of their insurance. It doesn't mean anything at this point. You really have to know what's going on with this person before you can make any decisions, right, or try to offer them.
You have to take a good history. The doctors and nurses take their history for their purposes. I have to take a good history because I'm not only speaking with medical people, I'm also speaking with psychiatrists, I'm speaking with insurance providers. Each one wants to know a different piece of this person's presentation, so to speak. And it's also just knowing that person, establishing the rapport with the person in that moment that they've come in. It's important to understand what brought you in. Why is it today? Why not yesterday? Why not next week? Today. And usually everyone has a reason.
That's true.
There's a different reason for every person, and it doesn't have to be something that was a crisis in their life to bring them in. It could simply just be that they have realized what a financial drain it is for whatever they're using, and that's is a definitely important motivation.
Okay. So when you say crisis, maybe it's not that it's a misnomer, but crisis doesn't necessarily mean that the person is going to jump off the roof, or the person got into an automobile accident, or the person wound up in getting arrested, or whatever the case may be. It can be something significant in their life that would bring them there at that moment.
Right. Something significant, something that's causing their life not to be functioning as well as it might have used to been.
Right.
It could be that there's maybe there are family issues. There was an intervention from the family. The family's very upset. And that is a crisis for that person in their family. The next person may have been arrested, and that's a crisis. Whatever caused that person to realize, I do need to stop, I need to get help, I need to do something. It's good to know what the motivation is, because that can be then passed on to each of the treaters while they're in the hospital, and that can be used to really frame out the discharge planning. So without knowing that, sometimes many of the people who follow with the patient after me, they also do a history, and so it may come out, it may not come out.
Yeah, I see what you mean.
But
some things are caught.
The patients very often are very interested in letting a lot of information out when they first come in, because they're upset, or they're not feeling well, or they just give a lot of information. And also, if there's multiple issues going on with them, from a psychological perspective, that's good to know, because that's very important in treating this person. And
so let's say the family comes in with the person, and the family would like to have this person receive help in whatever shape or form. Let's say I do, why don't you take him in and detox him? And the patient doesn't want to do that. You really have to go along with what the patient is looking for, right? That's not a case.
Right, and that happens quite a lot.
Yeah, I just said it because I'm sure people say, well, I'm going to bring you up there, things are just going to get done. But if the patient doesn't want to do it, then you really are
right.
in a problem.
If somebody comes in and it's for any reason whatsoever, any patient, we abide by what the patient wants us to do.
Right.
And unless a patient has someone who has a guardianship or a conservatorship or has some process in place where someone else makes the decisions for this patient, then the patient has all rights to let us know what he or she wants to have done. They might just want some medicine so that they don't feel ill, and then as soon as they feel better, they want to be discharged. Because recognition of the problem does not always happen at the same time it might be happening for the family and friends. And to appease the family and friends, the person comes in. But the patient is the person who has to really direct the treatment. Right. And we cannot force anyone to stay for treatment. We'll encourage it. We'll give resources, but we can't force anyone to stay.
Right. The reason I bring that up is because hopefully a lot of family people will be watching this tonight, and it's difficult unless the person really wants to have the treatment. To take the trip to the emergency room and just say, here, take care of him, it doesn't work. And it's nothing negative about that individual, because that's what addicts do and alcoholics do. They just don't want to have that. But you're right, if they're trying to appease someone else, it's not going to work for them also. So let's make the assumption that you have determined, after talking with the medical people, that they're medically cleared, right?
Right.
You've done your evaluation, you've discussed it with the psychiatrist, and the decision is, yes, this person needs to go through a detoxification process and then follow up with something else. Okay? So then you call Diane, and she says, I don't have any beds right now. Now,
well, generally we're going to know
what
that.
happens, and then I can give it over to your partner here so she can tell us.
Well, well, basically, if we've established the person can be admitted, as long as the insurance company approves it. I usually contact the mental health unit before I call the insurance company, letting them know, because they need some time to prepare, also coordinate services up on the floor, get orders from the doctor for medications. So while they're working on their preparation, I'm finishing up the paperwork aspect, the sort of administrative aspect. And then, so hopefully we get the approval from insurance. We register the patient. I then call the mental health unit and give them all of the background information that I've gotten. And we give a report on, a brief report, because I'm also going to be preparing a written narrative that they'll get when the paperwork goes upstairs. So I just give essential information. The nurses always ask questions if I haven't included something, so I don't have to be really elaborating on anything. If they want to know it, they'll ask me. And then sometimes things come up in giving the report that I need to check on. Maybe someone told us about a medication, and so I'm not medically trained, so I might not have knowledge of the medication. The nurse will ask, well, is there something else that this person takes? Perhaps there's two medications that usually go together. So I might do some backtracking on that. But also, if they don't ask me that, after I give report, the nursing from the emergency department also gives a report, and they give the medical treatment, meds delivered, anything from a medical perspective. And then usually the nurses can speak with each other and find out, So
you cover just about everything, I guess. It's a thorough process. It's not just a, I want to come in here. It's not that, hey, welcome to the Hotel California.
Correct.
Give me a bed. I'm going to stay overnight. That's good. That's very good. And then you physically bring the patient up to the inpatient
We bring the
unit,
patient upstairs, right. We bring the patient upstairs, one or two staff people. It's just hospital policy to always bring someone upstairs in a wheelchair, so we bring them up, their clothing, their paperwork. And it's a good way just to continue with that treatment so that the patient doesn't feel abandoned. Like, gee, I've just spent, sometimes it can be a good number of hours, unfortunately, but maybe let's say it's 2 or 3 hours as I'm working on things with that patient, and just to know that I'm handing them off to the next stage of their treatment. I wish them good luck, and then I go back to my work down on the emergency floor, and then the
another patient.
Mental health
and then
takes
you
over.
Take over. Yeah. All right, thank you, Gwen. That's very good. What happens now? The patient comes up to the unit. They're sitting in the room, and
they arrive on the unit, and a nurse would greet them, and do a quick evaluation to make sure that they look medically stable, that they look okay. We would then have them go into a private area where we can do a nursing evaluation assessment. And our goal for every client that comes up onto the unit for detox would be a safe and comfortable detox, as well as to have some supports in place for when they leave so that they can maintain the sobriety. We have a multidisciplinary team on the unit, and the first people that will meet with the client would be the nurse and psychiatrist if it was in the morning hours. The psychiatrists are available in the morning, and if the client comes in the evening, they'll be seen by the psychiatrist the following morning. But the nurse will see the client and do a thorough physical evaluation. We do a physical assessment as well as a mental assessment, neurological. We also take that important information that Gwen provides us with. We want to know how long they've been using the substance that they're using, if they have a past history, if it's alcohol per se, have they had DTs in the past, seizures, anything that can turn into a medical emergency. We want to be aware of that so we can medicate appropriately and prevent that. So we would do the nursing assessment, and we would educate the client on what to expect. If they were coming in for an alcohol detox, we would want to let them know what signs and symptoms to expect and to report to us. And we would medicate accordingly. Every detox is individualized, depending on the client, their history. If it's an opioid detox, it's the same. We would educate them on the symptoms to report to us. We would do a CWA scale for an alcohol with a detox, or an NAS scale, a narcotic assessment scale, and we would begin medicating them as soon as they arrive on the unit.
Can you explain what a narcotic assessment scale is?
A narcotic assessment scale is to assess the withdrawal symptoms from opioid addiction. And many of the symptoms would be nausea or vomiting, abdominal, stomach cramping, would be chills and sweats. They would have anxiety, restlessness. They may have muscle aches and pains. They may feel flu-like, very tired, achy, runny eyes, runny nose, craving. Sometimes they're yawning, feeling very fatigued, but they can't rest. They can't seem to sleep. Those would be the most common symptoms that we would find with this narcotic assessment scale. The alcohol withdrawal scale, we would be looking for symptoms such as mental status is very important to determine if they're going into DTs, which is a medical emergency. We would want to know if they know where they are, what the date is, who the president is, simple questions like that. We'd want to know if they were hallucinating, seeing, hearing things, having any kind of tactile stimulation, pins and needles in their extremities. They oftentimes have nausea and vomiting as well, sweating, tremors, shaking, elevated blood pressure and pulse, elevated temperature, things like this.
You know, if I were just listening to you for the first time and I thought I had a problem with drugs, there's no way that I would ever try to detox by myself. You know, I mean, it truly, I mean,
it's very uncomfortable.
It's uncomfortable, and I'm sure
unless you know. And I think clients feel more secure being in. We're an acute care hospital-based unit,
right?
So we have all of the medical resources available,
right?
And I think they feel more comfortable with that.
That's true.
Knowing
That's
that.
true. Yeah.
And we are able to. We do an opioid detox with methadone. That's. We have a protocol, and it's usually a 5-day detox. And not only are we administering methadone to alleviate those symptoms of withdrawal, it's a tapering dosage, we're also using other medications to treat the other symptoms that might be milder symptoms, but we'll treat those as well. The body aches, the anxiety, restlessness, insomnia, things like that, nausea. And the same with alcohol. We use Ativan, a benzodiazepine, and it's a central nervous system depressant. We're replacing the alcohol with the Ativan so that they don't end up in acute withdrawal. And that's also tapered over 3 to 5 days. And we will also medicate with other medications for symptom management.
To treat the symptoms. Do you get quite a few patients that have that are polysubstance abusers
Yes.
that would come in and you know, they're detoxing for alcohol, but
Yes.
they're also using opiates?
Yes.
And does that present a
It's very
bigger
common.
problem? Very common.
I would say the majority, first of all, of our patients, at least probably 80%, are duly diagnosed. Not only are they coming in with an addiction and requiring detox, they also have a mood disorder component. So we're also addressing that mental illness or mood disorder. But many clients come in with polysubstance abuse. And the most common would be the alcohol, the cocaine, and opioids. So that's very common.
Yes, I can imagine. When you mentioned cocaine, it's interesting because I've had phone calls from people telling me that I'd like to, you know, or my son is addicted to cocaine. Where can he go for a detox? And I have to tell him, well, he can't because there really is no, it's not a physically dependent in my That's correct. So,
Right.
And they'll say something like, you mean in Connecticut? And I said, well, really nowhere. I said, it's not that. But you're right. If people do have a cocaine dependence, even though it's psychological, there's a good chance that they be using another chemical
Right.
to
Usually that
alcohol
goes
or
along hand in hand with other substances.
benzodiazepines, whatever the case would be. Yeah.
We have a multidisciplinary team, as I mentioned, and when the nurse is finished evaluating that client initially, we have behavioral health assistants on the unit, and they will they'll manage the client in the milieu on the unit. They'll show them where everything is, where their room is. They can do their laundry there, their hygiene needs, their meals, ordering their meals, any of that. They'll assist them with those needs on the unit. Then we have clinicians that will evaluate the client in regards to their social needs or issues that they come in with, legal issues, occupational, financial issues. Oftentimes they will try to identify a sober support in the client's life so that they can have them come in for a family meeting and be part of the treatment inpatient and outpatient. We have occupational therapists who will lead groups and they'll help the client to formulate some goals that they can work on while in the hospital and as they leave the hospital, and work on activities that would help them to achieve those goals. And then we have the case managers, which help the client to find aftercare plans and effective supports for relapse prevention when they're discharged from the unit. So there's follow-through
Yeah, it's pretty comprehensive.
right into the next treatment
Right.
after they leave us.
So you have the BHA who takes care of the little familiar things that the person
Right.
knows, whether their laundry is there, whether their clothes.
Right.
And then you have the people to follow up with the various areas that you can guide them in the right direction
Right.
after they leave. So the ultimate goal for both of you, however, is to get that person back out into the real world.
Right.
Okay. Under combat conditions, I guess, whatever. And you do make referrals to a variety of places?
Yes.
When a person leaves?
We'll make referrals. We will meet with the client to see what their needs are and what their goals are. Oftentimes we may think the client needs a certain type of treatment, or the family especially feels they need to be in a residential program, when the reality is that it's probably going to be an outpatient program for that client. It might be their first detox. We will provide them with many resources. Some people have had many detoxes and they're not able to successfully maintain sobriety or clean time outside of the hospital, so they may be a referral for methadone maintenance or Suboxone treatment. We can provide that information. We provide information on self-help groups such as NA or AA, and we also have NA come in on the unit twice a week. They have meetings for the clients to attend. And then there's outpatient programs and there's residential programs, so we have a host of options for the patient.
So there's no pigeonhole type thing. Each person receives a treatment plan
It's tailored
based
to what
upon
their needs are, yes, and what
Okay.
their desires are.
Okay, that's good.
We have people that don't even complete the detox. They will leave because
Yeah, sure.
they feel that they're not ready for it.
Well, since I'm the last one who usually gets them after the end, I tell you, it's really important, and I appreciate everything that you both do, because if I have a patient for an intake and I have to sit down and say, who is this person, I will know a lot before I ever ask the person anything because of the information that you have, which happened when I walk to the door, and you can see things change as they go along. Once they get on the unit, they will maybe, like Gwen says, change something to, yeah, well, I really didn't mean that downstairs, but I really mean this now, and this is exactly what happened because Mom was standing there. I want to tell you, but this is really what it is. And it's very important, and it helps us an awful lot. It really does. And I'm glad to see, and I hope people understand it. This is not just a get this out of your system and you'll be fine thing.
Right.
The bottom line is that comment that I'd like to make, and I know you agree with this, is that when you walk out of detox, you're not cured in any way, shape, or form. That's the first part, okay, of the process of recovery for that individual. I'm all over the place, I think, sometimes. But it does help, and just, I mean, my phase doesn't mean it's the end of it either, because the person has to be able to develop their own support system, as you said out there. A truly good sober support system. AA meetings and NA meetings are good, but if the people just go to be there, that's not really the whole idea behind it, is to get some support, and they will meet people hopefully there that they can hook up with and get some ideas. One question I have to ask you, Gwen, a person comes into the emergency room and they are very intoxicated. They have a blood alcohol of maybe, well, give me a high one. Go ahead.
0.350.
0.350. Now the legal limit to drive a vehicle is 0.08.
0.08, right.
And that's pushing it. Okay. So
Yes.
0.350 is basically what, 4 times the legal limit.
Yes.
Okay. Would you try to get that person into a program at that moment, or would you kind of wait to see what's happening?
Well, that's a very good question, because doing an evaluation of someone who is intoxicated is sometimes just an exercise in frustration. But on the other hand, sometimes people can be very lucid and coherent. But even at that phase, you have to take into consideration they are intoxicated, a substance is affecting them. So any information I would gather, I always will follow up with as the person sobers up, and then I will compare it to what they might say. Sometimes the information can be accurate, sometimes it's completely different.
Yeah.
So it would be irresponsible to do an evaluation, consider that information to be valid, pass that on to any of the other clinicians that I deal with. So the person really has to, usually they sleep until they're more sober, and then we'll see, and you can see how they might change, either medically, if it's an alcohol issue, as the alcohol level reduces, that's when DTs or seizures or might be evident, so that then the medical piece can come in before they ever go to the mental health unit. But we would never take that information as being valid.
And oftentimes they change their mind
Oh, I can
when they're sober,
Yes.
I'm sure.
Yes.
and they don't want to. They want to go home.
But we never release anyone at that high of an alcohol level.
No,
we
I'm
never
sure- I'm
release
sure you
someone
wouldn't.
unless,
If they're lucky they're alive.
Correct.
At that point sometimes.
right.
I thank you, ladies, very much. I wish we had more time to talk about this, but maybe you can come back sometime with a little more detail in the future. But it's very good. At least people now will understand what happens when a person just walks into the emergency room and says, I need help. They get some help, and they're always referred to someplace else for help. So I thank you so much. And thank all of you for listening. Tune in next week. We'd like to invite you to come back and visit us again. Thank you. Have a good night.